We're gonna talk about, okay. Good afternoon, everyone. Today we're gonna talk about advanced care planning. And just to let you guys know that this presentation is being recorded. My name is Dr. Ehab Fadhel. I'm the Hospice and Palliative Medicine Fellow. And our program director is Dr. Burgos, who supervised this presentation. Okay, so first I would like to start with the topics that we're gonna cover today. So I'm gonna give you like an overview of advanced care planning. We're gonna talk about the surrogate decision making. We're gonna talk about goals of care conversation, living will, and when to consult us, palliative and hospice and palliative. So first I would like to start with a case scenario. So I have this patient, Mr. LR, 82-year-old that I saw before joining Larkin, who has advanced CHF, impairment in the ADLs and mobility as well, multiple hospitalizations, and was living with his partner. So he presented after discharge from hospital, and basically before COVID-19 hit, he was following with primary care physician, and he was doing okay. But after that, because of difficulty in scheduling, things like that, he wasn't following, and because of his age and comorbidities, he deteriorated. And basically, the patient came and he was very frail, very sick, and he wanted, that's when we started the discussion about advanced care plan. So unfortunately, this patient passed away after 3 months. And even though we were able to finish the durable part of attorney, but there were a lot of things like living will or polls, which we will discuss, or hospice referral that we actually referred, but he didn't have the time because it's a long process. So he didn't have the time to get the benefit of hospice. So basically, this is very common that we see this in clinics and inpatient and all that patients we don't have the conversation about advanced care planning with patients until it's very late. And I hope after this presentation, I can convince you guys the importance of starting advanced care planning early on. Okay, so what is the definition of advanced care planning? So advanced care planning, according to the American Geriatric Society, is the process of planning for future healthcare decisions in case we're no longer able to make these decisions on our own. So I think it's self-explanatory. And why do we do it? Like, why is it important? Why not just leave it till the end and that's it? Well, first of all, you don't want to reach a situation like this where the patient is very sick, unable to communicate with us, unable to tell us their wishes. We as physicians or clinicians don't know the patient wishes. The family also don't know the patient wishes. So this is not a good scenario to be. So that's why that's the most obvious reason to start advanced care planning. But there are also other ethical reasons why we are supposed to do advanced care planning. First of all is we want to respect patient autonomy. We want the patient to tell us their wishes, and we want to respect wishes and not someone else's wishes. Because you don't want the family to be guessing what the family or the patient wishes are. Second is you want to protect the patient against maltreatment, because if you're gonna give CPR for a patient who doesn't want, then that's not good for a patient, right? We want to mitigate any family guilt, and believe me, like especially in my experience, it's a lot of guilt when the patient doesn't know the wishes of the patient, and they're trying to kind of guess what the patient wants. The ideal situation is that the family know what the patient wishes and they communicate with you what the patient wishes, rather than them trying to figure out or making a decision on their own. Third of all is to protect us from litigations. So the thing with the advanced care planning is it's more crucial with age and comorbidities, but it can be done at any stage. But of course, the more comorbidities, the more the age, especially if you have like a terminal condition, terminal diagnosis, then it becomes even more important. And obviously it requires certain capacity. So patients with dementia, it's very crucial that you start advanced care planning before their capacity declines. We see sometimes a lot of cases, patients with advanced dementia and advanced care planning is never done, and it's too late to do it now. So that's not really the best scenario. We want to avoid that. Okay, so this is some literature review of the studies done about advanced care planning that I wanted to share with you guys. So as you can see here, about 90% of people say that talking with their loved ones about end-of-life care is important, but only 27% have done so. So that's why it's very important that you start the conversation. If you don't start it, most likely the patient will not start the conversation with you or with their loved ones. So you have to kind of initiate it. Advanced care planning was often found to decrease life-sustaining treatments, okay, obviously, and increase use of hospice and palliative care, prevent hospitalizations. So that means that a lot of patients want to be at home and want hospice and palliative care. They don't want life-sustaining treatment. A lot of patients are like that. It's just we never ask them. So that's why it's important to discuss advanced care planning. Discuss the goals of care, basically. So this another study that was done in California for the public showed that 80% of people say that if they're seriously ill, they would want to talk to their doctor about their wishes for medical treatment toward the end of their life. But only percent from the public have had this conversation. So this is very low. Okay, so now I'd like to talk about surrogate decision making. And the reason why this topic is important is that the patient needs to know, if they don't do advanced planning, who is the person who will be making decisions for them, like who's the automatic person, if they don't have a durable power of attorney or a health proxy. So I think we all know this, that basically, first of all, is the patient. So no matter what document you have, if the patient have guardian, whatever, if the patient having capacity, then that's what we follow. After that is court-oriented healthcare agent. Then is designated healthcare power of attorney. And then if we don't have any of that, we don't have someone from the court or from healthcare, then we go for surrogate decision maker. That's the default person if we don't have any documentation. And I think most of us studied in medical school about the hierarchy of substitute decision making, but really it differs from state to state. Some states don't even have rules of hierarchy of surrogate decision making. So it's just the physician kind of clinical judgment who should be the health proxy or the surrogate decision maker for the patient. Luckily in Florida, we have clear guidelines that we have to follow. And these are the guidelines in Florida. So first, you have to go with guardian. So if there is a guardian appointed by the court, you have to follow the guardian. Otherwise, it's going to be the spouse. There are no other documents, so it's going to be the spouse. If the patient doesn't have a spouse, then it's adult child. And if there are multiple children, then the majority of them. Then it's one of the parent, or like the parent. Then adult sibling. Again, usually whenever there are multiple siblings, multiple parents, multiple children, then we take the majority of the parents. Are kind of difficult because you usually have two, but usually if you have more than one, then you try to have the majority of them. If it's 50-50, sometimes it's difficult, then you need like a ethics committee or something like that to make a decision. Then it's adult relative, then it's close friend. With these two, the way you choose a relative or friend is kind of like physician judgment. So by judging who's showing special care for the patient, who's taking care of the patient, who's the person who knows about the patient and their wishes. If we don't have any of that, then that's when you call the ethics committee to assign a social worker, usually a specific clinical social worker that is licensed or trained to do this. Okay, so now that we know about surrogate decision making, I want to discuss the most important topic for this presentation, which is goals of care. I want you guys to be comfortable to do goals of care with your patients. And first, I would like to start with a video of an internal medicine resident. Mr. Brown? Okay, so we're gonna start this video, and I would like you guys to focus on how this resident did the goals of care conversation and tell me what went well, what went bad, and how we can improve and things like that. Okay? Yes. I wanted to come in and have you a conversation with you about your health. Get to know a little bit.
Tenía que estar ahorita una presentación en Zoom.
Ya, quédate bien.
Ahí después me sentaré. ¿Ahí llegó la comida?
Ya llegó, ¿verdad?
Please, guys, mute your phone. Okay, thank you. Kira, I wanted to come in and have the opportunity to have a conversation with you about your health. And get to know a little bit more about what's important to you. Is that okay? Sure. So I read in your chart that you've been admitted a few times this year so far. Third time this year. Third time. How's that? How are those experiences been for you? Right now, what's your understanding of where you're at with your health? Well, I have in terms of talking about your illness, what information about what might be likely to happen in the future would you like to know? So in terms of your safety, you're right that it's a disease that we can't fix. And is likely to get worse over time. That may result in maybe if your health is worsen, what are your most important goals? Big family? Big enough. Yeah, big enough. Are you married? Yes. 50 years. So it sounds like it's really important to you. And what are your biggest fears and worries about your health? Biggest fears being on a machine. You make cloud. Can you tell me a bit more about what it was like when you saw your father in the hospital? What abilities are so critical to you that you can't imagine living without? That inability to communicate clearly. That's why. If you were to become sick, how much are you willing to work for the possibility of living?
What if it meant coming into hospital?
Yes. Right.
Short leave term.
Short.
In terms of your health, one of the things that I'm worried about is that, as we talked about, your disease is health. And what you've told me is that family and being at home are very important to you, as is the ability to communicate and share with people. There's two things that we need to talk about today. The first one is resuscitation. Resuscitation is essentially if your heart to stop beating. We need to have a conversation about what we would do in that situation. And from what you've told me, it sounds like if you had to be in a machine or in an ICU setting for a long period of time, that wouldn't be too
Yes.
So I'm worried that with where your disease is at, that if we resuscitated you, so they attempt to start your heart beating. I understand your wishes, and that's not what you want. What I also hear you saying is that you're not ready to give up, and I'm not ready to give up on you either. Right. So what that means is that do not resuscitate does not mean do not treat. So if you were sick, even in a hospital, like right now, we'd still give you antibiotics if you were okay with that.
Yes.
And we do things like give you IV fluids if you needed them, or medications to help you in improving your health or your symptoms. That sounds okay. The other thing is that if you came in and you were quite sick, and you were having some difficulties with breathing like last time you were here, I do think that it could fit with what you were hoping for to do a trial of BiPAP again, which was that mask that you had in the ICU. We consider that a non-invasive means of helping you with breathing because there's no tube that is there and you're not attached to the machine. But it does mean that you're getting some additional support for your breathing. Do you think that would be something that you would find tolerable? Do you have any questions about anything that we've talked about in terms of resuscitation or medical treatment? How much does your wife and your family know about your priorities and your wishes?
I think the whole idea.
So what I'd like to do is I'm going to document in your chart that if you were to have cardiac arrest or your heart wasn't beating, that we wouldn't do things like CPR, electric shocks, or attach you to a machine in the ICU. But that you are very okay to do a trial of that breathing mask should your breathing become labored or need support, and that we'll continue to give you things like IV antibiotics or fluids and treat you medically.
Don't give up.
Yeah, we won't. Okay. So what I'm going to do is I'm going to make those documentation in your chart, and then tomorrow, if your wife is here, I'm happy to kind of have that conversation and keep her in the loop as well, because she sounds very important to you. Okay, great. Thank you so much.
Okay, So right now I'd like maybe someone to volunteer, maybe preferably a resident, to tell me what went well and what other things can be better, and then basically tell me their opinion of what this resident did, because she's also an internal medicine resident. So anyone wants to volunteer and give us their opinion from you guys? No one? Okay, fine. Okay. Can you speak louder? Sorry.
She was sitting at eye level.
Okay.
She was explaining
Okay. Okay. So I have someone here telling me that the patient was sitting. The physician was sitting at the same level of the patient, good eye contact, and discussed every like communication skills were good. Any other comments? Okay, thorough and covered everything. Okay, what else? Okay, even non-residents, anyone?
I think few important points in this case was the way she started, like asking him initially, what's his understanding about his illness, what he knows so far, and how much he want to know about his illness. So it's very important when you start that conversation to exactly know what the patient has the information about his disease and how much more and how much different treatment options and whatever he wants to know. So that really helps you out, and who is important to him in his family. That really helps you out to define what would be the goals of care and the translator.
Okay, yeah, excellent. So basically, yeah, so the one of the good things that she asked first, what do you know about your condition? So you want to know the patient perception. Sometimes you'd be surprised. You go to a patient who has stage 4 cancer and you'd ask them and they would say they don't know that their case is terminal. So, and they didn't have that conversation with their oncologist. So that happens. So please first know the perception of the patient. And another thing is that I heard is about health proxy. So the resident asked about who's important in your life, who knows your wishes, and it was the wife, and she asked to bring the wife for future visit to discuss with the wife and make sure that the wife knows the wishes of the patient. So that was good. Any other comments? Okay, so basically, I'd like to go through these points. So these are the things that you want to do. This is one of the most important slides in this presentation. So these are the things that you want to do when you want to approach and start a goals of care conversation. So first, like our medical student said here, is the environment. It's very important to make sure that patient is comfortable, it's the right time. Sometimes you don't want to do it on your first meeting with the patient. Maybe you want to form rapport and do it later. You want to be like our medical student said here, at the same level of the patient. You don't want to be standing while the patient is sitting. Eye contact is very important. So all these things are very important. Second thing is to introduce yourself. So she introduced herself. I'm the resident, I'm the medical student. You have to introduce yourself, of course, just like any other interaction with patients. Then take permission. Tell the patient, I'm going to discuss with you about goals of care, about your wishes, about what's important for you, and your values. Use these words. Is it okay? Because maybe the patient it's not a good time. Maybe he doesn't want to, or she doesn't want to discuss goals of care right now. So take permission. Then is the perception, like Dr. Khan said, understand the patient perception about their condition. What they know, where they are. Do they know that they're terminal? They're not. What exactly they know? And then knowledge. So that's when you have to give them information. And the way you give them information is, like we're going to discuss later, is the ask, tell, ask. So what that means is it's conversational. It's not giving a bunch of information at the same time. You ask them about their perception about something, then you tell them. So the way the resident was doing is that, okay, so it seems that, so first she asked about the perception of the patient, then it says, oh, it seems like you don't want to be intubated, but you want BiPAP. And then he says, yeah, so it's conversational. Ask, tell, ask. So that's the knowledge part. And then you want to ask the patient about their what's important for them and their fears. Like this patient said, my fear is I don't want to be on a machine like my dad. So you want to know that. And then the coded status, that's when you discuss DNR, DNI. So you can see how many steps that we took before discussing DNR. You cannot just go to a patient and discuss DNR. That's not really the best case. So you want to do all that before and then discuss DNR, DNI. Then is the durable power of veteran. Like she said, okay, so it seems like you, who's important in your life? It's your wife, okay. And I like that she said, okay, I would like you to bring your wife for next visit, and we're gonna discuss this, make sure she knows your wishes and respect it in the future. Okay, so in this slide is the 5 wishes. These are usually what patients want at their end of life. They want to know when. So they want to know who's the person that will make decision for them. In that case, it was the wife. They want to know the medical treatment, what kind of medical treatment, how comfortable they want to be, how I want people to treat me, how they want to be treated basically, and what they want their loved ones to know. So this is to continue the goals of care. So it's very important to be compassionate, listening. So listening is more important. Don't just give information, listen to the patient, very important. We talked about ask, tell, ask. So make it conversational. It's not just you telling the patient. Patient gives you some information, you give them knowledge, and then you ask them again. It's conversation. Give small pieces. And that's why, like, make it conversational. Small pieces, not just bombard them with a lot of information. Ask about the big picture. What's important for you? What are your values? Like she asked, how long you're willing to go for a little bit of time, how much comfortable you want to be. These are very important. Big picture. Be truthful without fear of stealing hope. So a lot of times you don't want to give information because you feel like if the patient knows, then it's going to cause anxiety and the patient might get sick. But actually in literature, it shows that it's the other way. Actually, there's no evidence that withholding truth is going to benefit the patient or reduce anxiety. A lot of times the other way, the anxiety of the unknown, when the patient doesn't know what's going on, you see that it's deteriorating, but no one's telling them what's going on. So the anxiety of the unknown is worse. So, and it's unethical. You have to be truthful. If you're not, then you're lying to the patient, and this is unethical. So that's another reason as well. Can't do that. So, okay. So involvement of family, caregiver, and loved ones. So you can see in this case, she figured out that it's the wife, and she asked to bring the wife so that she can have a conversation with them and make sure that the wife understands the wishes of the patient and respect them. And also that will help with the anxiety of guilt of the wife, of the health proxy, because if she knows the wishes of the patient, it's going to be her telling us the wishes of the patient. Not a lot of guilt, right? But if she doesn't know, then she has to assume. She has to assume what the patient wishes. Because the way we ask the question to the health proxy is what the patient wishes. So even if the patient is unconscious, we have to respect the patient autonomy. We cannot ask, give me a decision about this. No, it's always, what do you think as his wife, as his daughter, as his whatever, as a relative? What do you think the patient wishes in a case like this? Okay, if they know, if the patient said their wishes, then that's easy for them. If the patient didn't, then for someone who knows the patient, what do you think is best for him? Okay. And the last one is involve other interdisciplinary team members. So make sure that all the other teams are in the same kind of picture, in the same page as you. Okay, because you don't want a physician telling something and another clinician telling another thing. So these are all important things that you have to be aware of when you do the goals of conversation. So another thing that's important, which is actually very important here at Larkin, is translation. So goals of care is a very difficult conversation. And unless you speak the language fluently, bring a translator, better a professional one. And it's better to make sure that the translator understands that they're gonna translate exactly what you say. So if you tell the patient, I think you have this or whatever, then they would say the same thing. I think you have this condition, instead of saying, oh, the doctor is saying this. And you want to be the one in eye contact with the patient, not the translator. The translator is a translator, not a messenger. So they just translate exactly word by word what you're saying. And usually what I like to do is I'm facing the patient and the translator is in a 90 degree, or maybe closer to me, something like that, where the patient is looking at me and hearing the voice of the translator. Okay, so role of hospice and palliative care. Okay, so this is the last portion of the presentation. Now that we're done with the most important part, which is the goals of care, I would like to talk about when should you guys consult us, right? So hospice and palliative, I think all of you know about hospice. And all of you know when to consult us when you need us, when the patient is hospice eligible. It's usually when the patient is in their last 6 months of their life, or life expectancy of 6 months. So I'm not going to talk too much about hospice, but I would like to talk about palliative care, because a lot of times people don't realize that like the old-fashioned way, that it was okay when the patient in their last 6 months of their life, then that's when palliative and hospice come in. But with now it's showing that with research that it's better to involve palliative and hospice care earlier on, at any stage of the disease. That's palliative care. Okay, so as you can see here, at any stage of the disease. Okay, and it's usually we focus on quality of life and making sure the patient is comfortable. And this is basically, this is the slide that is kind of illustrated for this. So you can see that once you have a terminal diagnosis, that's when you involve us. The old version is that palliative was never involved until it's too late. Now what we want is whenever you have a terminal diagnosis, then you want to involve us. So let's say the patient is having, let's say stage 4 prostate cancer. Patient is going to live more than 6 months most of the time, but you want to involve us. And at the beginning, our involvement will be low, but mostly like clinic visits to the palliative clinic, making sure that the patient is comfortable, their symptoms are well taken care of, their advanced care directives are there, patient wishes are respected, things like that. And then, so when the patient condition becomes advanced, it's going to be easier to transition. So it's a smooth transition, not just a sudden transition. That's what we want to do. So that's what palliative care is. Okay. This is also to show you that palliative care is the big umbrella. Then this is hospice. So palliative care is more of patients who are living with life-limiting illness at any prognosis, as you can see, symptom management, quality of life. Sometimes we do chemo, radiation, and palliative surgery, even though the more recent studies are showing that their role is very limited. Maximizing community support, and very importantly, psychological support. And I think most of you guys know about end of life. So this is hospice, and this is terminal care. This is at the end, like basically this is days to hours, this is 6 months. So that I think you guys are well aware of. So we're not going to talk too much, but this is the one I want you guys to focus on. So if the patients have an terminal condition, COPD, congestive heart failure, Alzheimer's, involve us early on. Doesn't have to be hospice, but involve palliative. Okay, so possible appropriate scenarios. So these are just examples. So a lot of times, if you're having a patient with multiple hospitalization, difficult to control physical and emotional symptoms related to serious illness, weight loss that's not improving, patient family uncertainty regarding prognosis goals of care, request of futile care, if the family is requesting or patient requesting futile care, DNR orders conflict, there is a conflict. These are mostly social and psychological issues like declining ability to complete activities, so ADLs, impairment, limited social support, like patients homeless, chronic mental illness, patient family physician request for hospice. Of course, if the patient wants hospice, then you want to involve us. A patient of family psychological and spiritual distress as well. Okay, so now this is a small portion. I just want to talk about some documentation. So living will, this is when, if you have a patient that's not sure and about if their health proxy understand their wishes, then that's when you want to do a living will. You want to advise the patient to go to a lawyer or a notary service where they can actually document exactly what they want. A lot of times, some patients sometimes don't want their family to take the burden of making decisions for them. So living will be a good option for these patients. So do not resuscitate. So this is the order, this is the form that you guys all know about, the state of Florida form. There's also a form for Larkin. You have to make sure that this is really the form that is recognized all over the state of Florida. The Larkin form is only for Larkin. So when you discharge patients, please send them with this form. And I think most of you guys filled this form, so I'm not gonna go through it. But I would like to let you guys know that there is a more detailed form called POST, or Physician Order of Life-Sustaining Treatment, because the DNR form is just DNR, right? But if the patient is more, if the case is more complicated and you want more details, then there is the POST, and it's also recognized in the state of Florida. And it basically has sections where you can talk about resuscitation, and then here, the different levels of intubation and ventilation. And then you document about feeding and about the durable power of attorney, if there's a hospice. So all these are documented. So it's a more detailed form. And and these are the instructions. Like if you're gonna fill it, just follow these instructions. But I've seen this mostly used in clinics because it's more details. But in terms of inpatient also can be used if you're looking for something more detailed and something more like if you have a complicated case, like it's not DNR, they want CPR, but they don't want to be shocked or something, or they don't want to intubate, something like that. Okay. So now I would like to, now that the presentation is done, but I would like to have some clinical cases that I'm gonna read, and then I'm gonna ask someone to kind of give me their opinion of what they would do. So here I have a 77-year-old man with CHF admitted to the hospital with acute pulmonary edema, requiring emergent intubation. He's found to have a left ventricular ejection fraction of 5 to 10%, very low. He remains poorly responsive to hypotensive and he's hypotensive and ventilator dependent. He completed an advice directive several years ago when he was hospitalized elsewhere and identified the wife as a proxy, but his wife died. So we don't have a proxy. His 2 daughters are his next of kin. The treating physician scheduled a family meeting to discuss the goals of care. So this is an unfortunate situation where you have a proxy, but the proxy passed away, so you don't have a proxy anymore. So you're gonna have to find a surrogate decision maker through the hierarchy that we talked about. Okay, so how should the physician approach decision making for this family? Anyone wants to read the options and give me their opinion? Okay, I can read the options and then you guys can tell me what you think is best. So the decision is to be made by the physician based on the judgment of what the patient best interest given his medical condition. The decision is to be made by the older daughter based on the statement in the patient advance directive and based on the understanding of the patient values. The decision is to be made jointly by the patient's daughters and the decision based on the patient clinical situation and his values. The decision is to be made by the patient daughters based on their understanding of patient values. Anyone wants to volunteer? So this is someone impatient. This is a case scenario that any internal medicine resident can face. Anyone wants to tell us what they will do? Anyone from internal medicine? No one?
I think
Sorry? Last one. Okay, so let's read the last one. The decision is to be made by the patient's daughter based on daughters based on their understanding on their patient value. Okay, so this is the second best option. Yes, C would be the best option because the only thing is, of course, that it's better to take the opinion of what daughter than the older one. That's not appropriate, and A is obviously not appropriate. But the difference between C and D is C, we're gonna sit with both daughters and we're gonna tell them, we're gonna try to figure out what the patient wishes. While D is we're asking the daughter to make decisions. So that's not appropriate because you are putting a lot of guilt on the daughters because they have to make that decision. And we're also not respecting the patient autonomy because it's not the daughter's decision. It's the daughter's understanding of the patient values. That's why C is a better option than D. Is that clear? Okay, so let's move to case number 2. So a 70-year-old woman with metastatic breast cancer is a refugee who recently came to the United States with her family from Nepal. She lives with her family, including her husband, son, and grandchildren. She's currently hospitalized with functional decline and a new diagnosis of malignant pleural effusion while undergoing chemotherapy. You have been consulted to assist in conversation regarding goals of care, which have been difficult for primary care team because the patient only speaks Nepalese. So here we have a case with language barrier, which we see a lot here at LARC. So which of the following steps should be involved in planning and conducting the family meeting? So choice number 1 is ask the patient's granddaughter to interpret because she's the most fluent in English. She's the most fluent English speaker, and the patient has been relying on her during the hospitalization. Talk with the interpreter outside the room to explain ahead of time a summary of the things you will be talking about. To allow for clarity during the meeting, address the interpreter using phrases such as, please tell her that. Use a Nepalese American hospital employee who has offered to help interpret because she's fluent in both languages. So which one is the most appropriate out of these? What do you guys think? Being residents at Larkin, you should be able to, you have dealt with this case a lot of times. So anyone would tell me what they would do? So it's you want to do goals of care with a patient that doesn't speak English and you don't speak their language. So what do you do? C. Okay, to allow for clarity during the meeting, address the interpreter using phrases such as, please tell her that. Okay, so like I mentioned in the presentation, we don't want the interpreter to transmit a message. We want to directly talk to the patient, and the translator is only translating exactly what we say. So if we say, let's say, I think you have COPD, the interpreter should say, I think you have COPD, exactly what you said, and should not say, oh, the doctor is saying you have COPD. So that's why C is not appropriate. Anyone else want to try this question?
The B option, talk with the interpreter outside the room.
Anyone from internal medicine? No? Okay, so yeah, B is the best one because first we're using a professional interpreter, and second of all, before coming to the patient, we're telling them and we're probing them and telling them exactly what we want, which is basically to interpret exactly what we're interpreting, to make sure that we are the ones that have eye contact with the patient, we're facing the patient, and their role is only translating exactly word by word what we're saying and not adding anything. Okay, so I hope that one is clear. So now it's the last case, and I think we have 5 minutes left. So you're consulted regarding goals of care and prognosis for a 47-year-old hospitalized man with metastatic pancreatic cancer that has progressed in spite of standard chemotherapy and participation in a phase 3 clinical trial. He's now bedbound, sleeping 80% of the time or of the day, is dyspneic at rest. Prior to your visit with the patient, you call the patient oncologist who relays that he has had a really hard time addressing the prognosis of the patient cancer with the patient and the wife. And he appreciates your upcoming attempt. As you are about to enter the room, the patient wife stops you in the hall to make sure you aren't going to talk about dying with the patient. She's worrying that if he hears how sick he is, then he will become depressed and give up. She also expressed that she doesn't understand why the oncologist didn't tell them in the clinic that what was going on. Okay, so what should you say to the wife regarding the communication with the patient about his condition? So first of all, let's go back to the scenario because this is a bit of a long scenario. So here we have a case of 47-year-old with a terminal diagnosis, metastatic pancreatic cancer, which is a very progressive cancer, as you guys all know. And the oncologist didn't discuss, for whatever reason, and wanted you as a palliative fellow or physician to talk to the patient. And the wife is telling you that she doesn't want you to talk to the patient about dying. She doesn't want you basically to tell the truth. She doesn't want you to, because she's afraid that you will give up or give up hope. So what should we do? So this is a bit of a difficult question. It's more for a maybe a palliative fellow, but if anyone wants to try it, okay, maybe Dr. Ambar Khan, because you're the palliative fellow here. You want to read it?
Yeah, just let me read it. So what should you say to the wife regarding communication with the patient about his condition and prognosis? While many doctors and family members worry about stealing hope, studies do not show an increase in anxiety or depression when prognosis is openly discussed. That seems like an appropriate answer. The next option, I don't want to steal the patient hopes, so I want talk about these hard truths. That's kind of telling a lie, which I would go for. Oncologist faculty didn't have enough time to do the conversation justice, and clinics so perhaps didn't bring it up for that reason. You cannot blame another physician. So oncologist tried to communicate with you, but you were not in a place to be able to accept the information. I guess A would be the right option.
Yeah. So yeah, exactly. This B is not telling the truth. C and D are you're blaming the oncologist and the family that they weren't able to communicate. So that's not appropriate. What's appropriate to do is basically reassure the family that stealing hope is not really a thing. Okay, the patient usually wants to know the truth, and not knowing the truth actually causes more anxiety. And the studies are showing that telling the truth is the best thing that is, or like hiding information is not going to help the patient. It's not going to reduce anxiety. So that's why you want to assure the wife or the family, and you have obligation to tell the full truth to the patient. Okay, so these are my references, and thank you everyone. Any questions or comments from anybody? Anyone? Anyone from Zoom who's joining us want to ask any question or give us their experience or share with us?
Again, Dr. Ehab, thank you for the presentation. I guess was a great presentation. If there is any other further question, please, let us know.
Okay, any questions? Okay, yeah. The first case. Oh, okay. So this one. So here we have a case of, so the patient has a health proxy, but the health proxy passed away. So we don't have a health proxy case. And we have just the two daughters. So what are we gonna do? So you have options where you make the older daughter make the decision. Of course, no, you have to ask both. And you don't really ask the daughter to make the decision. It's always first what you want to try to do to respect the patient autonomy. So you want to, instead of telling the daughter, so this is not just for advanced care planning, but of course more important when we're making goals of care conversation. So you want to tell the daughter, what do you think are the wishes of the patient? Or you can ask this way, if your father is here, what do you think he would want? If you're gonna ask the question, what's the decision you're gonna make? You're gonna ask them to make the decision, then that's not appropriate because you're not respecting the patient autonomy. And second, you're putting a lot of guilt for them to make the decision. In reality, you're supposed to make the decision. It's a shared decision between you and them based on the patient wishes and not them making the decision. It's you and them trying to figure out the patient wishes and making a decision based on that. Sorry?
If the wife was alive or something, if there's something written down, how would that change?
Yeah, so if the wife is alive, it would be the same thing. We would ask the wife, what do you think the patient wishes are? You never ask the family to make decision. Sometimes they say, I don't know their wishes. So you ask them this way. You say, okay, if knowing the patient, since you're the wife or the daughter, and you know the patient for so many years, what do you think he would want if he's with us? That's the second thing that you do. And unfortunately, sometimes they tell you, I don't know, I don't have a clue. Or they don't know the patient. The surrogate doesn't know the patient. Or the health proxy. That would be complicated, like if we have no clue. But you would want them to make the decision based on the patient wishes. If the patient said, I wish this and that clearly, then you want to follow that. If not, then you want to tell them, knowing the patient, what do you think is the best? Okay? Ethics committee is involved if there is a conflict. Like let's say the one daughter is telling you that my patient wants this way, and the other is saying, no, my father never wanted. So there is a conflict. So that's when the ethics committee gets involved and figure out, basically, if they were trying to figure out who is telling the patient wishes and who is telling their wishes. Because you want to figure out the patient wishes and respect that. So that's, but that's like for, that's too complicated. That's for the ethical committee to figure out. So if there is a conflict, involve ethics committee. Any other questions? Okay, thank you everyone for joining. There are no more questions. We'll end this session. Thank you.